Welcome to Season 4 of Healthcare Rounds. Here we explore the vast and rapidly evolving healthcare ecosystem with leaders across the spectrum of healthcare delivery. Our goal is to promote ideas that advance the quadruple aim, including improving the patient experience, improving the health of populations, lowering the cost of care, and attaining joy in work. I'm John Marchica, host of Healthcare Rounds. I'm also the CEO of Darwin Research Group and faculty associate at the Arizona State University College of Health Solutions. Please don't forget to rate and review us wherever you get your podcasts, and send your questions, comments, or ideas for Healthcare Rounds to podcast@darwinresearch.com. Let's get started.
Our guest today is Dan Pelino, well-known thought leader, author, and co-founder of Everyone Matters Incorporated. He is a regular contributor to the discussion on healthcare, citizen-based services, and smarter cities. Having appeared on CNN, Bloomberg, and other media outlets, he serves as a moderator and host to the current healthcare debate and is a professor lecturing on leadership at Western Kentucky University. He has worked for IBM for 36 years, leading its global healthcare and life sciences business for 10. Now co-founder with Ann Altman of Everyone Matters Incorporated, Dan has served on the executive committee for the Patient-Centered Primary Care Collaborative and on the board of directors of the Healthcare Executive Network.
So Dan, thanks for taking the time to talk today. Really appreciate your setting aside 30 minutes or so. When we first met and I asked about your background, you gave me an interesting answer. And you said that you're a community builder and not a community owner. What did you mean by that?
Well, within the world of healthcare, most people define themselves as I work at a hospital or I'm CEO of a hospital or a system, or they say they're a doctor. People that are in the health insurance business work for an insurance company. People that work in pharma work for a pharma company. And those that work in the health government aspect are government employees, but they work, whether it's in the United States or around the world, they work for a government in the world of health. I'm none of those. But I worked with all of them and trying to help them build the best healthcare systems that could possibly be. And I had a chance to work with these great leaders around the world, see what they were trying to accomplish, ask them questions about why they were doing what they were doing, see the results that they were able to post. But you see, I'm not an owner of that P&L. I'm not an owner of that result. I may be an influencer on the idea, but I'm really not the owner of the idea. I was an enabler. I was a community builder. I brought people together. And I believe that healthcare is a concentric circle that is made up of hospital systems, made up of insurance companies, made up of pharma, and of course, government, with the patient in the middle, patient-centered healthcare. And so I, along with the people that worked with me around the world, we built that idea forward in something called the Patient-Centered Medical Home. And then we helped with the integration of healthcare systems, which continues to happen every day. We helped insurance companies move from providing insurance to be more of a health company. We helped pharma be more active within not only trials, but then how they would do outreach into patients, into that patient-centered medical home. We helped governments look at best approaches of government spending and involvement. So you see, I'm a community builder. I built a community made up of all of the stakeholders in support of the patient. So someone once, I didn't make that name up, someone bestowed it upon me, just like my friend Dr. Paul Grundy was bestowed upon the godfather of the medical home, patient-centered medical home. People would say, you want to talk to Dan because he's a community builder. He doesn't have a dog in the fight, but he has seen the best and he works with the top leaders in government healthcare, all aspects. And so he's got some interesting opinions about what's worked and what hasn't worked. So he's worth having a conversation with. And hence, I'm a community builder versus an owner.
Got it. So I don't want to bring this up so early, but I'm going to. About halfway through, a third of the way through your book, Trusted Healers. A lot of authors come on healthcare rounds, and I always ask them the same question. What was the motivation behind writing the book? What drove you to write this? And then with your collaborator, is it Bud Ramey?
Yeah. Well, I want to give you 3 points that are of value. When IBM asked me to take on the responsibilities I did, it was the first time they didn't put a doctor in that position. You see, I'm a behavioral science guy. And in my career at IBM, even though IBM's a significant technology company, IBM also likes to chase after grand challenges. And I would be one of those people because of my background and looking for value, that they would put me in those leadership roles to look to create value and solve, or at least try and advance some of those challenges. So Sam Palmisano at the time was chairman, and he asked me to step into the healthcare role, healthcare life sciences, and try and tackle this. I called one of my best friends, Dr. Chris Dengler. I grew up with Chris. He's just a terrific leader on his own right. And he said, Dan, if us docs were so smart, we wouldn't be in this problem that we're in. We need someone like you, that you don't have a dog in the fight, that you can bring us together to the table, and you can work with a company like IBM where you have a pretty strong balance sheet, and you guys, you're widely respected on solving grand challenges. You put a man on the moon, for God's sakes. So you should do this. I gathered a bunch of people together, actually 137 people, for a week. We put together work plans and things that we would do, as you normally do when you're running a big portion of the business.
Sure.
Fortunate to do that. At the end of the week, these people had presented back to me things to do, and including this integration around the patient of hospital systems, insurance companies, and pharma. Nobody before had really spent a lot of time trying to connect those dots in support of the patient. They gave themselves a standing ovation. I told them at that time, this work is so terrific that someday someone's going to write a book about what you've done in support of the patient-centered medical home, what you've created. Little did I know that it would be me that would do that. And when I retired from IBM, people came up and said, Dan, you have to write the book. You've done this. You've been with these people for over 15 years. You've created this value. And at IBM, we had a pretty strong record of financial returns as well. I bought $4 billion worth of company within that period of time, supported through the organization to continue to create value. And then I would, at the end of all of my speeches, when we would continue to go forward, I would ask people in the audience, why do we do what we do? And they'd look at me with the stare of the Wisconsin dairy cow. What's he say? And the answer is, why do we do what we do? It's because everyone matters. Because everyone matters. So the idea of creating this continuum of care, what Paul Grundy talks about with the patient-centered medical home, in this intersection, is in support of the patient and in support that everyone matters. Everyone should be entitled to this type of healthcare. And so to answer your question, I was fortunate that IBM asked me to get in the middle of a grand challenge, supported me with acquisition, a terrific team, and we had a great run. And the reason I wrote the book was because upon retirement, the team, my clients, people in the media said, you have to write the book. And Patrick Kennedy wrote the foreword, as you know.
Yeah.
My friend Patrick Kennedy is just a strong, significant voice in mental and behavioral health. And never thought I'd be on the Dr. Oz show. Never thought I'd do over 150 podcasts. Never thought that I would find a voice in support of all the people that are doing terrific work in support of a better healthcare system. So that's how we got here today.
So you write a lot about, at least where I am in the book, about Dr. Paul Grundy. Tell me about your relationship with him and why he's kind of the centerpiece of the book.
Well, Grundy's an interesting person. So he did work for me for IBM, but before that he had worked in many organizations. He worked for 4 sitting presidents. He's a Quaker by background. His parents were Quakers. Worked with Nelson Mandela. He was the ambassador to Denmark, knighted in the UK. He is around the world recognized as one of the strongest leaders and the voice of the patient-centered medical home. He's one of the most interesting people you've ever met in your life. He's tremendous at what he's been able to do to influence and bring community together, including supporting the primary care docs, the RNs, the PAs, et cetera, the continuum of care, understanding how specialty works within that. And he has been really the galvanizing force in how you should think about the continuum of care. And of course, the example that I love to use is the fact that in the past, many of us would go see our doctor and we'd fill out the obligatory information on the clipboard. We'd turn it back in, go into a file folder. It would be put outside a door. There'd be a rustle outside the door. There'd be a knock. A doc would come in or someone would come in. They would have read our information. 5, 10, 15 minutes later, we walked out of there with a prescription to go fill, and then they were gone. And we may never see that person again, kind of like a cowboy or a cowgirl riding into town and then riding out. Well, in the world today, we are more like a race car, a Formula One car, a NASCAR, and we are in the race of our life. And what you and I want out of our healthcare system is a pit crew where everyone in there is wearing our colors, an RN, a PA, primary care doc, specialty as we need them, mental behavioral health help if we need, and they call us in and they say, hey, it's time to come in and change the tires. You know, it's time to come and get your flu shot. By the way, your blood pressure's a little high, you're running a little hot. We got to go pay attention to that. And maybe we need to sideline you for a little bit and get you back out after you get ready. We are in the race of our life. We are that NASCAR. We are that Formula One car. And what we need and what we want and what we deserve is a pit crew of healthcare professionals that help us be the best we can be.
So who's doing this well? If you can name names, obviously, I'm sure you've seen, and I'm wondering if you have a domestic example and then maybe an example from another country. Who's got this patient-centeredness in the patient-centered medical home? Who's doing this well? Who's got it right?
Let me start with your second question first, because around the world, we see that the countries that are performing best spend 14 to 20% of their first dollar on preventative care, well care. We in the US only spend 5% of our first dollar on well care. We spend more on sick care. So we've all heard the debates. We
Right.
don't need sick care, we need well care. And sure enough, Denmark, Sweden, many of the other countries that perform far better than we do in the World Health Organization and longevity and spend far less, they are far more aggressive up front. Now, here's what people would say to me, and I've worked with these countries and helped them build out their system. I'll just pick on Denmark for a minute, because they're usually right at the top, if not always the top. At 5.5 million people, that's a fraction of 330 million people.
Of course.
And so, for instance, when Blumenthal came in as head of Health and Human Services, he said, Dan, where should I go? I sent him to Denmark. He came back and he said, Dan, there are only 5.5 million people. How can I take this out to the rest of the country? And I said, well, the reason you can, and I'll just use you as an example, you're in Arizona.
Right.
You're in the Phoenix proper area. Let's say there's 5.5 million people within that area proper. How many people go outside of the area for their health care? Not many.
Right.
90% of the care that the 5.5 million people. So when you start to look at then the dominant healthcare systems like Banner and Mayo, et cetera, they can take those ideas like they have in Denmark and apply them into an integrated care model, into a primary care extension, continuum of care, et cetera. And that's what they do. Banner's pretty good at it. Mayo's obviously, Mayo has two models. One specialty, you go up to Rochester, Minnesota, when you might have a serious concern. But Mayo, what they've built out in your area is very good with the continuum of care in expansion. And that's why we're seeing this consolidation of healthcare systems, because they want to put together that continuum within the organization that they build. And so that becomes in-network. You and I know that as in-network today. So when we see the ideas, the best performing systems, many of these ideas came from these countries that were able to have better feedback from their patients, better outreach into their communities, more around preventative care, well care models, et cetera. And so that's where we are. We need to do more of it in the US. And we do, we just need to. We've always been specialty. From Flexner Report in 1911, where we built specialty care. And docs came in and they studied, and then they went out into an internship and rotation. Most of them wanted to go into some kind of specialty. More money was there. Primary care was thought of something that, just a family doctor does. And it wasn't perceived as the most important part of care, the front door of care. It wasn't thought of as well care. But we now know that we can't leave this problem at the doorstep of the emergency room. And the specialists want us to be able to be well. So when we come to them, they can do what they know they need to do. So it becomes important, this continuum of care that we talk about, this patient-centered care, starts with preventative care. And that's what we write about in the book. We bring those ideas and questions you should ask your doctor and things you should think about into the idea of preventative care, primary care, working with RNs, PAs, that primary care doc up front. And that keeps you out of the emergency room, keeps you out of the hospital, helps you spend significantly less in out-of-pocket on your healthcare costs. And it is the answer to what our country needs to do in order to lower costs of healthcare, and it'll be far less expensive.
So Dan, how do we align incentives? Because if I'm going to be, I'll be skeptical of what you're saying and say, well, Banner, they make money on procedures. They're out. They just acquired, if I remember, if I'm getting the right health system, just acquired another hospital. They've got the Banner MD Anderson Cancer Center. They've got the Neuro Institute. They've got all these things that are based on doing procedures, fee for service, right? So how do you align the incentives to get a Banner, which gets paid predominantly for doing things, to align on what you're talking about?
Well, let's just start with the elevator conversation with the CEO of Banner. And here's the three things that he or she wants to talk about. First of all, help me get my cost in line so I'm not out of control of my cost. Second, how do I keep my referral patterns within my network, within my hospital?
Right, no leakage.
Leakage. And three, can you help me think about other services that I should provide that are specialty that I can get into? Could be breast cancer, could be prostate cancer, could be GERD, but specialty that you might not have today that end up giving you advantage of scale because you have an in-network, and then the specialties that communities need attention. Where we need to go is value-based care. So value-based care is where you're managing a population and you're managing them to be well, and you get paid for managing them to be well. And we have found, working with Cleveland Clinic and many of the other systems that have gone forward, that if you can get people to the right aspect of their life with BMI and glucose levels and no nicotine and the 6+2 that I talk about in the book, the chances are that these people are going to be healthy and spend less money in the system, but you should be incented to keep them healthy. And that's where we're going today, value-based care models. Now, one of the challenges is you're scoring a non-event. You're paying someone to keep them well.
What do you mean by that?
Well, today, as you said, everything's really based on some type of episode of care. Mm-hmm. So there's some level of episode of care. What you and I want is we want someone to keep us well, make sure that we are as best as we can be, back on that racetrack of life that we talked about earlier. So does it make sense that you pay someone to manage a population so they're healthy? That's the only way you would get away from the episode of care payments, is to move towards a value-based care system. And you should incent the individuals that are in your healthcare system. Pay people to be well. pay them to get to the right BMI levels, pay them to get to the right glucose levels. And we have found that roughly $1,000 to $1,200 a year is an incentive to be able to get these people there. I'll give you another example of how this plays out. Do you know that 40% of the produce in the US is sold through a Walmart?
No, but doesn't necessarily surprise me. Big retailer.
And would you know that roughly 40% of the people that come into Walmart cash their check there?
That I did not know.
So when you start to think about reaching the demographics of the people that are served by a Walmart, what does it look like if you have primary care that might be connected to Banner, but at the Walmart? And you create an incentive where somebody comes in that might be driving a truck, has got a gun on the back, might be a little bit overweight, might have a little issue with their glucose level. But you say to them, I'll tell you what, if you can get to these levels by, let's say, 6 months, you see that 55-inch television set over there? That can be yours. Create an incentive system. So it doesn't necessarily have to always be money. It can be other ways depending on the demographics. And we have to have care meet people where the people are. Instead of having the guy with the F-150 in the gun rack having to drive to the hospital system or a doc, why can't we have these extensions at places like Walmart? And Walmart's starting to do this and have them connected on the front end with RNs and PAs and maybe a primary care doc connected through to Banner. And you see, we then start to be, and we can have the conversation where the individuals are towards wellness, towards preventative care, and stop diabetes and stop this poor individual potentially from having to do an amputation or become diabetic. So these are the ideas.
Is Walmart thinking that way? I haven't had a chance.
Yes, absolutely. Yeah, absolutely. I help them think about many of these things. It's taken a little while, but they're definitely going that way. These are the fundamental changes that we need to have within our society in the US to have healthcare meet people where people are. And then we can get them in to be able to do preventative care. Right now, today, wherever you go, I can almost guarantee you that if you look at it, and your listeners right now are listening to you and me, count how many signs free flu shot today. You can get a free flu shot at CVS, Walgreens, Walmart, depending on what grocery stores. Here I'm on the East Coast, Wegmans, free flu shots. So you see what I'm talking about. It's this idea of being able to meet people in this world of preventative care where they are. And then we get a chance to keep them out of laying this problem at the doorstep of the emergency room when they get really sick. Or potentially using the emergency room as their primary care door.
Right. You know, it's interesting, the example that you gave. I think about ACOs, right?
Yeah.
And very much so in line with what you're talking about. So all the things that they're trying to track, at least, and they're not without their faults, but just the general concept is let's look for those markers where people are sick, and let's focus on preventive care, right? But one of the things that is a problem, I think, with the ACO model and what docs will say is, well, hey, I'm accountable. What about patient accountability, right? Well, when you get the example that you gave with that 55-inch TV, which today probably costs Walmart $50 to buy, maybe less. Now you're aligning. Now you're giving people an incentive beyond just, yeah, I know I should stop smoking, or yeah, I know I should stop eating all these sugary foods. Now you're giving them something and that's more likely to have an effect, rather than just, a cash payment, like $25 or something, right? So I think that's interesting. I wanted to get to the question about behavioral health, because Patrick Kennedy did write the foreword, and we know he's been a champion behavioral health issues for some time. What are we getting so wrong about behavioral health?
Mm-hmm.
What is it that we're getting, and how do we raise these concerns and bring behavioral health issues more to the forefront?
Well, first of all, the stigma has been around mental and behavioral health for a long time. People didn't want to talk about it. I had a chance to be with Dr. Oz and with Patrick on this exact point that you're bringing up. We were on the show last October, and October 28th or so. So we got into the conversation of check up from the neck up and know your rights and things that you should think about. People just haven't talked about these things. So the first thing is you have to have that conversation. The second is that Patrick and I worked on a lot of the infrastructure, and given your background, you can appreciate this. So first of all, the primary care docs did not necessarily have the mental and behavioral specialists within their network. And so they didn't really want to refer out, even though they were more check up from the neck down as opposed to check up from the neck up. So oftentimes, if they did refer out, they didn't get the patient back because it wasn't connected in the system. So the electronic medical records today have the ability to capture that information in structured data so you can pass it back and forth. Also, the incentive systems have changed. So the incentive systems to ensure that the primary care doc gets paid for referring out and being able to be recognized within that process. And although that may sound disingenuous, it's important because that's their livelihood and they should get paid for doing the right thing, et cetera. And the last is the insurance companies didn't spend a lot of time on this in the past. It was difficult to get reimbursed. And there was a very significant ruling, Witt versus United Health Group, that the Supreme Court ruled on, where the Supreme Court ruled in favor of the family, saying that United could have done much more to help and in the reimbursement model. Now you see ads on TV in the last year or so about checkup from the neck up. It's amazing how this has turned, because the Supreme Court said no. People are paying into those healthcare benefits for a top to bottom, from head to toe. And you have to pay attention to that. And you have voices like Patrick Kennedy talking about the challenges that he's had. And we're smarter, by the way. We're smarter. We've had issues that have just accelerated this. OxyContin, for instance, painkillers that people used, brought out in the late 1990s. That was under do no harm, and doctors thought that they were non-addictive, and they would prescribe 30, 60 pills of that. Well, guess what? Addictive. So these people were cut off, and then they started going to heroin, and that's when the heroin epidemic was there. And then people started to say, hey, this heroin stuff, get it out of here, catch them, all that. Now they're on fentanyl. And so it's like China doll and it's China powder, and you don't even know where this stuff's coming from, but just a fraction, a small coating could kill you on fentanyl. So here we are 30 plus years since we started with the do no harm, that it causes tremendous harm, and it just exasperates. So much of what's been done is awareness, a lot around infrastructure and payment reform that's been significant. And the other is stepping up to the issues that have gone before us that need to be addressed. And with that, and as your listeners are listening, don't let your kids vape.
Right.
That's on the front end of some of these problems. And we're starting to see issues on this vaping. I'm not saying it's good, bad, different. Pay attention to it. Pay attention, because there's aspects of that vaping that are not good at all. And they could be under the same thinking of other things that have happened to us in the past. Does history repeat itself? And I would say yes.
Yeah, I went through that, the whole fight with my three kids as they were going through, that 14, 15, 16-year-old, that, and it's everywhere. It's everywhere, especially at that age and even younger. My youngest was facing these issues in middle school,
And they have mental behavioral aspects to it, right? So it's not just, there's peer pressure, there's other aspects, as you know, I mean, living through it as you did, and as you know, maybe you do, but this is important. And the most important thing that we can do as elders in our society is healthcare literacy. The good book, the Bible, talks about 40 years. It's referenced 146 times. Why does it reference 40 years? It's because it's a generation. Mm-hmm. And I don't know about you, but I'm not sure I received a lot of healthcare literacy when I was a young boy. You know, I had the appropriate birds and the bees conversations, but I didn't have others about what you should eat and what you should do and how you should exercise, et cetera. There may have been the president's patch on fitness that you got at school if you could do push-ups and sit-ups and climb to the top of the gym.
We had that.
A short amount of time.
Yeah, we had that.
But it's not the same, right? We should leave a legacy of healthcare literacy, and that will help more than anything else in every race, every population, every gender. It should be so important because we've learned so much. We've seen what society is, and we owe it to our kids to have that conversation on healthcare literacy.
Now, it's going to sound like I'm getting political, and as folks who listen to the podcast know that I generally shy away from politics. It's bad for business. And I will say this, in the face of what you're talking about, we've had however many years of let's repeal Obamacare, and now we've got the ACA in front of the Supreme Court that probably is going to strike it down on a technicality. I think these are related. These issues of what you're talking about and understanding healthcare and understanding taking responsibility, personal responsibility for yourself, for the things that you put in your mouth, for how much sleep you get at night, all of those things is related, because I know that fundamentally, I don't know if we talked about this previously, but this whole idea, this notion of prevention and the patient-centered healthcare is at the core of the ACA. I mean, it's behind a lot of these things. It was. And some of my professors were involved in, helping give advice as well.
Sure, I presented to the president on this. Yeah, absolutely, and I'm
President Obama.
And I presented to the 219 congressional leaders that voted in favor of it under Nancy Pelosi's leadership at the time, along with Mark McClendon. They asked us to come in and say, all right, tell them what they just voted for. Not that they didn't know, but to be perfectly clear about this continuum of care, this front door of care, this primary care aspect that was so important, and why you needed to have your children on a plan, and why you needed to have something that had no pre-existing condition issues. So I'm aware of it. I've been right in the middle of it. I'm in the middle of it today. I have a chapter in the book, Right versus Privilege, and I'm happy to have a conversation about it because it's grounded in facts and in the most impressive systems in our country today practice what's in and defined in the Affordable Care Act.
So why is it, again, now this is maybe where it does get political, why is it that you have 40% of the Congress, 50%, depends on which area you're talking about, that doesn't understand this, or that doesn't prioritize this, or doesn't think that it's important, and finds, Obamacare like the evil that it is? And why is that?
Right. Well, a couple things. First, people, unfortunately, they don't really understand the importance of this. That's part of why I wrote the book, and I've done, over 150 podcasts, and a lot of this health literacy, what you and I are talking about, and how important the front door care is. We as a country are still well behind, and we have ways to go. Second piece is that there is a lot of influence through insurance companies and pharma to be more involved in the influence to get rid of the Affordable Care Act. And the reason is because there's less reimbursement within that for different groups. It's not that they are greedy and they all want, but they're business models, and the business models have to change. Everyone is going to have to do something. We pay the most for care in the world for the worst care. And part of that is because we offer choice, 4 ways to pay for care: VA, Medicare, Medicaid, health insurance, and go alone, where you have no insurance. Americans like to have choice. Now, do you think we pay for that choice? You bet we do. It creates a lot of the inefficiencies that we have, but people want choice. And so consequently, they don't like the idea that government says, well, we want you to do this and not that, or we're trying to influence you to do this or not that. The truth of the matter is, the best performing countries in the world in health, they provide more service to their citizens than we do. And when we repeal, if it happens, then we're going to have to reset what that looks like. And I'm hopeful that we will reset under the guiding principles of the patient-centered medical home and many of the things with the Affordable Care Act. You know, one of the small challenges we've had is, if we had ever been able to move from Obamacare to the Affordable Care Act in name alone, we may not necessarily be putting it in front of the Supreme Court to repeal it. It's that political because people think it's Obamacare as opposed to the Affordable Care Act. And in order to have the Affordable Care Act approved, it wasn't the president signing it into law as much as it was the votes to support it. So the people voted, people associated his name with it because he was there at the time. And I think sometimes people get a little incented based on a previous party or a previous leader, regardless of the outcome. Mark my words, if it gets repealed on the technicality, watch what comes back. Watch what comes back. It's going to look markedly similar. And people are going to say, wait a second, you put pre-existing conditions. I thought you didn't want pre-existing conditions. Oh, you're allowing children to be, oh, I thought you wanted that off. Oh, you did with prescription medication. Oh, wait a second, isn't that what was here before? We've already seen some of the ideas for the next health plan, and they look remarkably similar, but they don't have the name Obamacare. Remember, I'm a behavioral science guy. So
Yeah. Well, that's very true.
Some people will argue, by the way, the mandate. Some people will, rightfully so, argue the mandate, which was a cornerstone to have people that are healthy pay into the system to afford people that are not healthy the care that they deserve. So, but things have changed on some of that aspect. I mean, you can still have the principles of the Affordable Care Act without the mandate. And we've proven that to be true. What I really believe in is, let's drop the age for Medicare down to 55 so that people that are starting to get older get the right kind of care. Many people that retire, they leave themselves without care until they are Medicare eligible. And if you get past 57, so says Cleveland Clinic, without any significant conditions, any chronic diseases, then parts are parts, and you're going to live a really good life as long as you don't start doing things you shouldn't do and live dangerously. So we need to capture these people into a primary care setting before they get too old, and we can capture some of these issues. And then on Medicaid, let's raise the poverty level so the underserved get a chance to have good care. And because of the challenge that we have on Medicaid, on how low the level is to qualify, there's many people that are underserved. And if we raise that level, the poverty level, we'll allow more people that are underserved to receive care. And if we do it right, put these people in preventative care, it will cost us less money. Again, we score a non-event. We move towards preventative care. We move towards well care. And these numbers, these hold. This is the mandate that we should accept and we should work towards and celebrate. Let's move towards well care, drop the age for Medicare, raise the poverty level, let Medicaid people get in. We don't need to have a Medicare for all. We can still have private insurance. We can still have choice. Let's allow pre-existing conditions. And if you want, we can call it whatever you want to call it.
Does that mean that we're going to have to go to something national for Medicaid as well? Because we tried the Medicaid expansion, and some states opted in and some states didn't. Now, you could argue even the expansion states, the poverty level still is too low. But, you know, I'm wondering politically, how do you get that done?
Well, a lot of people have offered Medicaid expansion. So there's many states, and by the way, it's okay to let states decide, because here's what states look at. The insurance commissioner has a responsibility here. Let's just say, which is true, you're in Colorado. And let's just say in certain areas within Colorado, there's one health insurance company. And you either have insurance through that company, or you go alone because it's too expensive. And because it's the only game in town, are those prices too high? Should we not have an option for those people that look like Medicare product? Should there not be a government option when there looks like there's a monopoly? I think we say yes, there should be. And watch what happens. Free market. Those prices will come down. Now, hospital systems are going to say, you know, my reimbursements, et cetera. But let me go back to what we said earlier. The CEO says, help me get my cost out. I don't want any leakage. And where can I build additional services so that I can add to my revenue line? How do I run this thing efficiently? What should I acquire next? How do I expand this so I give the best care to my community? It works. It can happen.
Well, Dan, we've run a little bit over, but I've really enjoyed this. I enjoyed the time talking to you. Had a lot of other questions, but you kind of got to them. So I hope that we stay in touch.
My pleasure. Yeah, I'd love to.
There's a way that we can end up working together. Your advocacy is strong, and your ideas are very strong as well. So hopefully we'll be able to find some common ground here in the future.
Thanks for having me.
All right, thanks, Dan.
From all of us at Darwin Research Group, thanks for listening. Healthcare Rounds is produced by me, Kim Asciuto, and is engineered by Andrew Rojek. Theme music by John Marchica. Darwin Research Group provides advanced market intelligence and in-depth customer insights to healthcare executives. Our strategic focus is on healthcare delivery systems and the global shift toward value-based care. Find us at darwinresearch.com. See you next round.